All right. Well, it's 5 past the hour, so I think that we can go ahead and get started and at least kind of get through our housekeeping items. So, welcome everybody to our third and final installment of the Transforming Schools Through ACEs Awareness webinar series. Again, for those of you that are rejoining us and for those of you that are just coming into our space for the first time today, thank you so much for making time for this in your schedules. We know how busy and hectic things are right now in this chaotic world we're in, and we will do our best to stay on schedule today. My name is Jeremy Braithwaite, and I represent an organization called EvaluAct, and our organization is a partner to Healthcare Integrated Services on this project. And we'll talk about the background of that in just a little bit. But we just have a few housekeeping items that we wanted to run through before we get started today. First, the first two webinars, webinars 1 and 2, are currently posted on the Healthcare Integrated Services website. For those of you that attended webinars 1 and 2, we sent you a link to your emails with a link to access those recordings, and we will also be sending that out to everybody following today's webinar. We are recording this webinar today, and that will also be posted along with webinars 1 and 2 on the Healthcare Integrated Services website. We will also be reaching out to everyone via email tomorrow or in the next few days with some materials and resources that we reference in today's session. And finally, we'll also have an evaluation survey that comes to everybody tomorrow. It is a brief survey in SurveyMonkey. If everybody can take 5 to 10 minutes to fill that out for us, we would greatly appreciate your feedback. I know people are probably getting slammed with different requests and so forth, but this should only take 5 to 10 minutes. So we would appreciate if you could fill that out for us. So as you all saw in our advertisements, our webinar series is focused on transforming schools through ACEs awareness. And for those of you that are joining us for the first time here today, let me explain a little bit of the background of that. HCIS and EvaluAct have been working together for a number of years in the areas of primary prevention, trauma-informed care, and social determinants of health, and really centering that work where we believe it is most important and effectual, and that is among our youth and within our school systems. And as we've done this work over the years, we realized what a truly unique position schools and school health providers are in to help detect, treat, and mitigate the impacts of the problems that students are facing. And during a time of a global pandemic, I'm sure we can understand just how important that is. And so we put together this webinar series as a vehicle to communicate some of the lessons learned and best practices that we've picked up over the years with screening, identifying, and treating for adverse childhood experiences. And this is our way of joining forces with the ACEs Aware initiative, which we'll explain about in a little bit, with this goal of building capacity of providers to ensure a healthier future for our youth. So as I mentioned, this is the third and final of our webinars in our webinar series. For those of you that were not with us previously, our first webinar was focused primarily on issues of screening and disclosure. So that first step in the journey to providing care, how do we detect these issues in the first place, and picking up on the very subtle cues that might exist. Our second webinar, again, these are posted on the HCIS website, but the second webinar was focused around once we've detected or screened for ACEs, what comes next in terms of services planning and services delivery. And today we are going to present the final chapter in our story, discussing continuity of care. In other words, how do we ensure that students continue to receive the care, the ongoing care, as many students need, the ongoing care that they need to make sure that their needs continue to be addressed. And closely allied with that is how do we ensure that providers themselves are staying healthy and maintaining wellness throughout this process. So that's just a little taste of what we're going to be talking about today. I'm going to quickly introduce our panelists that we've put together for this for today's webinar. Again, we have a very another diverse group of experts that have joined together to tell this story today. First, we have with us Dr. Edna Miller, the founder of Healthcare Integrated Services. Dr. Miller's academic background is in criminal justice and educational psychology, and her earlier career was centered primarily in correctional rehabilitation, and she's worked in various correctional settings throughout California. And it was through this work that she became very aware of just how important early detection and treatment of issues in childhood are in order to prevent the school to prison pipeline. And that most certainly includes the impact of adverse childhood experiences. And that was the backdrop against which Healthcare Integrated Services was founded, with the goal of providing health, wellness, and life skills services to youth, particularly those youth in our most under-resourced and underserved communities. Justin Miller is the president and chief operating officer of Healthcare Integrated Services and is responsible for all the day-to-day operations, from critical licensing, contracting compliance, auditing, credentialing, hospital privileges, and everything in between. In 2019, Justin, in recognition of his service to students and families in the Los Angeles community, he received the California Senator Stephen Bradford and Assemblywoman Autumn Burke's Recognition Award. He is also a former McNair Scholar. Dr. Bernard Hardy is the Chief Medical Officer of Healthcare Integrated Services and a family practitioner of more than 35 years experience, 20 of those being in both inpatient and outpatient settings at Kaiser Permanente. And he also has 10 years of experience in school-based clinic settings. Nurse Amy McConnell is a family nurse practitioner of over 35 years experience, and she assisted with the development of a school-based ACEs and trauma screening at Healthcare Integrated Services. Amy also supported the stand-up of a very specialized universal screening program, which she will mention a little bit later in our webinar, that received funding to provide ongoing screening for ACEs among the student population. Amy's also a certified Medi-Cal provider and currently leads a primary care unit in Santa Barbara. And finally, from Dovetail Learning, we have with us today Brian Clement, Director of Program and Partnerships. Brian's passion is creating trauma-informed and healing-centered schools. He previously served on the Marin County First Five Commission. He worked as an ACEs interface presenter with the County of Sonoma and has done extensive policy education work with the California Campaign to Counter Childhood Adversity. In all of his work, Brian pushes and advocates for systems reform and eliminating barriers to opportunity. So, as always, we've brought together this group of very interdisciplinary experts that are going to be talking about continuity of care for adverse childhood experiences from multiple lenses. And so I think we have a very exciting webinar today. And at this point, I'm going to turn it over to Justin Miller, who's going to moderate the rest of our discussion.
Fantastic. So let's jump right into our learning objectives for today's webinar. First, we will increase awareness about the ACEs Aware initiative. Secondly, we will be able to understand the significance of establishing trauma-informed resources for youth at risk for social and emotional trauma, as well as the efficacy of continuity of care. Thirdly, we will understand the importance of self-care and resilience building. Fourth, we will share lessons learned from our frontline experience in addressing trauma. And lastly, we will be able to apply our knowledge gained in our discussion of our final case study today. So in this segment, we'd just like to give an overview on what exactly ACEs Aware Initiative is, as well as give a brief review on our previous webinars of screening and coordination of care.
ACEs is known as the Adverse Childhood Experiences. We are happy to be a part of this leadership. The ACEs Aware Initiative is part of a statewide effort led by the Office of the California Surgeon General to cut adverse childhood experiences and toxic stress in half in one generation. The goal of ACEs Aware seeks to help Medi-Cal providers understand the importance of screening for ACEs and training providers. The ACEs pioneers of this first of its kind effort is led by Dr. Nadine Burke Harris, California Surgeon General, and Dr. Karen Mark of the Department of Healthcare Services. The LEAs, local education agencies, are school districts, county offices, charter schools, community colleges, and universities. The billing option reimburses the LEAs the federal share of the maximum allowable rate for approved health-related services to Medi-Cal eligible students. Now, even though we're focused today on schools and health clinics, remember this is a statewide initiative available to all eligible providers. What does ACEs Aware offer to Medi-Cal providers? Please visit www.acesaware.org. You will learn information about training, screening tools, and clinical protocols. If a provider would like to receive Medi-Cal reimbursement, you must become ACEs certified. Now, let's talk about getting certified. Medi-Cal providers are eligible to receive payment for conducting ACEs screening for children and adults. You must complete Becoming ACEs Aware in California. This is a complimentary training. Most of us will benefit from CEUs to renew licenses or job performance requirements. Eligible providers will receive 2 CEUs. And lastly, you must self-attest that you have completed this training. We talked about on the previous webinars the pediatric ACEs and related life event screeners called PEARLS. This form was created by Dr. Dana Long. This is the required form necessary to receive Medi-Cal reimbursement. Of course, ACEs has been around for decades, but to receive reimbursement for this new specialized initiative, you must utilize the PEARL screening tool. Visit the website and you will find age-appropriate forms for adults, teens, and children.
Let us review how we do coordination of care for adverse childhood experiences, or ACEs. At HCIS, we do 4-step process. Step 1, we do comprehensive medical needs assessment. This is provided to students so that we can assess their physical needs, behavioral needs, and social health issues, as well as their current exposure to adverse events. Step 2, we design service plans. These are designed for individual students. It includes the provision of services by the clinic, and we also do an overall needs assessment of each individual student. Step 3, for coordination of care of ACEs, we try to do follow-up appointments to make sure we're monitoring and maintaining continuous contact with the students to see how they're doing. We at HCS do a follow-up appointments with students to ensure that their needs are being addressed. We also decide when they need to be referred to the appropriate specialties for interventional assessments. Fourth step we do is a treatment collaboration. Usually, I and Amy McConnell, our chief nurse practitioner, get together at least monthly to review the patient cases to determine what's the appropriate level of intensity in terms of needs of assessment. This may be high, medium, or low, depending on each individual student. And how often we monitor them is a function of how intense their needs assessments are. Also, how urgent their referrals are is also related to whether they are high, medium, or low intensity. So overall, we follow the four-step process and found this to be very invaluable in terms of our success with coordinating care for adverse childhood experiences.
So in this next section, we'd just like to share our story on how we address continuance of care. Continuance of care began with HCIS physician evaluation of high-risk youth utilizing universal screenings. We practice physician and nurse practitioner follow-up care routinely throughout a patient's educational growth to make sure the patients who received care were experiencing positive changes from when we first encountered them. As mentioned in our previous webinars, student patients would come to rely on our clinic as a safe space to check in with our healthcare professionals as well as support each other. HCIS followed up with moderate to high-risk patients and examined changes from baseline to determine whether these changes were in response across certain behavioral health indicators. At times, a patient will utilize these check-in moments to report the status of their care, such as losing their contact information for referred services, high-intensity symptoms despite the current regimen of care, or everything in their care is going perfectly fine. HCIS referred patients with chronic illness or exacerbated ACEs for follow-up care with the new or existing resources. So for reported ongoing ACEs, our physician or nurse practitioner would always confer with the healthcare professional who was referred to share in the concerns of the patient. And at times, we would work together with this referred healthcare professional towards an alternative treatment plan. Additionally, continued ongoing check-ins for moderate to low intensity cases would occur during our monthly care meetings with local and school district resources. HCIS maintained the continuity of care with their school-based patients through telehealth to ensure no negative consequences from delayed preventative, routine, or chronic care. Maintaining communication and care with student patients is incredibly important, especially during unprecedented times of crisis, where symptoms of ACEs can worsen. Additionally, there are preventative steps in continuity of care from a clinical perspective.
So timely follow-up. We include, once we determine that a student has a high grade intensity condition or underlying health condition, we include parents or guardians with the at-risk students in those cases. Our internal interdisciplinary process is to monitor high intensity levels students with reduction methods for next level of health condition or behavioral health indicators to measure outcomes. Continuous training with all the medical staff responding to patients with best practices for trauma-informed care. And finally, coordination of care with a network of care providers, school counselors or mental health care providers, social services, school principals, IEP coordinators, and others as necessary. So ongoing monitoring and interventions, we have been very lucky to be school-based, that we have access to the students on an ongoing basis to catch things that develop in between periodic health visits with their own provider, or things that for students who have things that have been missed, or things that conditions that exist that have for students who've never seen healthcare providers. So we continue instituting principles of trust, safety, collaborative decision-making with our students, parents, guardians, and school faculty, and a network of care providers. We provide patient education on toxic stress and intervention strategies to regulate stress responses, including supportive relationships in group sessions with family members, with peers, or counselors, the importance of physical activity, mindfulness and meditation, adequate sleep, mental health care, including psychotherapy or psychiatric care, and substance use disorder treatment when necessary. It is important to establish the physical and emotional safety of patients with mutually agreed upon goals, with coordination of care providers, including school disciplines, to ensure close monitoring and monthly contact, or more frequently, depending on the intensity of the case, to resist re-traumatization of patients who have experienced ACEs.
So in this next segment, we just like to emphasize the importance of resilience and self-care.
Well, thank you, Justin. And I just want to appreciate everyone on the call for all the work you're doing. And as was stated, in this network of care, those that are doing the work need to take care of ourselves. We create the conditions and environment of those that we are trying to serve. And I just wanted to say that this has been a difficult year. Obviously, and wanting to acknowledge that which is going on down in the LA Unified area as we all look to work together to move forward. Part of my love and passion is applying the work of self-care into this context in a trauma-informed way, touching on so much of what Amy just mentioned. And I appreciate the opportunity to share our program called We Are Resilient, initially titled to work within PBIS structures. We are safe, we are respectful, we are resilient. And part of that self-awareness and self-care starts with the acknowledgement of our own patterns and identity through our cultural resilience and patterns that we've experienced in our formative years, our own protective patterns, our reactive resilience, the things that we do to keep ourselves safe. And then we've put together a curated set of research-based skills for our own personal resilience, our ability to build relational resilience, and then as well foster group positive resilience. On the next slide, I wanted to name and put a word to what we are all collectively experiencing. It's called surge capacity depletion. And surge capacity is defined as the a collection of adaptive systems, mental and physical, that humans draw on for short-term survival in acutely stressful situations, such as natural disasters. And here we've been in an extended time having to develop and use our systems. So on the next slide, we talk about one such skill within our approach called nurturing myself. Often we hear the term self-care. We decided to title the term nurturing myself to give more of a proactive approach to meeting our own needs in a holistic way. Self-care sometimes is typified by, I'm tired, so I need rest. I'm hungry, so I shall eat. With the skill of nurturing myself, we hope you will build and create systems and practices to nurture all areas of your well-being, including social, physical, intellectual, emotional, and spiritual or purpose-driven life. And in the context of schools, it's best expressed with this quote here on the next slide, that we talk about schools can't become the best places for students to learn and grow unless we make the best places for teachers to work and grow. So part of our work and our offer within the program, We Are Resilient, is to help schools and school communities, their families, build a caring, connected environment through our program and with training that we all, in fact, can be our best selves, and that we, in fact, are the cure for the toxic stress that we're experiencing. The next slide has a brief list of resources, and Want to invite any partnerships, inquiries, and possibilities about how we might support the School Climate Initiative in this integrated healthcare model. So appreciate being on the call and look forward to more time and opportunities to share.
So in this next segment, we'd just like to share in what we took away from our experiences utilizing telehealth during COVID-19.
During the COVID-19 pandemic, we were able to deal with the negative consequences of a closed school system so that we could maintain connection with our students. And telehealth was a lifesaver. Obviously, allowed us to overcome the negative consequences of delayed preventive routine primary care and maintain connection is the main thing with our students. The telehealth also allowed us to identify emergencies. Even though we were not able to be face-to-face with the students, we were able to identify those who had a physical or a mental emergency. For example, if they had an emergency with regard to the suicidal thoughts, we could call the PET team, which is the psychiatric emergency trauma team, which would come to them. Social services, important. If there's a situation where abuse or neglect was identified in the home. And finally, we were able to notice that the telehealth allowed us to maintain a level of trust between us and the student patients, which is very, very important. So the take-home message is this: telehealth is very important, especially during the pandemic. It allowed us access to the students. It also, in spite of the unprecedented life events associated with the pandemic, it allows us to still maintain that connection. And finally, we can say that telehealth is a very effective model, especially during the pandemic, allowed us to alleviate the high levels of increased toxic stress that was impacting the communities as a result of the pandemic. So we're grateful for telehealth.
So in this next segment, those who attended our previous webinars may remember that we like to share in the lessons learned from our experiences in addressing continuity of care. HCIS would find students who would turn to substance abuse to self-medicate for underlying ACEs. And so during our continuance of care screenings, we found patients reported indulging in self-made substance abuse, such as Red Bull mixed with Advil, cough syrup, and other substances, instead of following the referred professional's treatment plan, or the patient was still waiting for a treatment plan to be established. So what we learned is it is important to develop protocols to work with referred healthcare professionals to ensure timely care for students who were referred for ACEs. This is because symptoms of ACEs are ongoing. So timely and consistent follow-up care is needed, along with ensuring the patient understands the significance of following the treatment plan towards positive outcomes. If the referred healthcare provider is unable to provide timely care, we found it beneficial to have a network of care in order to refer to an alternative professional that could see the patient sooner.
Oftentimes, students self-refer to the health clinic, or they were referred by school district personnel because of disciplinary action, and it was later discovered that unclosed ACEs, crisis, or trauma was involved. There are many cases of detention or disciplinary action a student may face in school when uncovering revealed circumstances require intervention. For example, a student was sent to detention because he refused to remove his hoodie in class. When screening was conducted by the clinical nurse, the student was found to have an infection in his head. He did not have insurance or medical support to receive treatment. Therefore, the student refused to remove his sweat jacket with the hood, which subsequently led to disciplinary action. It is common for a student to receive detention for refusing to remove hoodies. It is not common for the detention to have untreated related health issues. So what we established at our health clinic was protocols to work with school campus police, probation, and intervention officers, including mental health therapists or providers, to closely examine antecedent behavior and clinical treatment measurements when students present with disciplinary cases involving undisclosed ACEs, crisis, or trauma.
Lack of follow-up care leads to exacerbated trauma and underlying health conditions when private community physicians are unavailable, which is probably more often than not, or the student doesn't have access to local network care, they don't have insurance, they don't have transportation, they don't have a parent available or guardian available, or they don't feel comfortable in disclosing to the guardian what's going on. I've had plenty of students who live with father, grandfather, uncle, and they're not, female students aren't comfortable in talking about their health needs with that family member. So they just go without. I had one case, I was actually just reviewing a note written at the very beginning of our program. This was going on for more than 1 year with this one student. In the physical exam, I noticed that she had a systolic heart murmur and some other symptoms. She was, her skin color was paler than usual for her ethnicity. She was complaining of shortness of breath. She had palpitations. She had early fatigue, and she was a cheerleader. I had forgotten that this had actually gone on even the year before we finally resolved it. It got so bad that she quit the cheerleading squad and was just extremely symptomatic. It came to the point where I said, you've got to take care of this. I'm going to give you a note. I need you to take this home to Grandpa, and Grandpa has to take you to the doctor for blood work. I suspected that she was extremely anemic, which can affect learning and cognition and brain development. And she said, okay, I'll do it. The wonderful part about being at school was that we had access to these students. So I had her back the following week. Have you done it? No, I lost the paper. Okay, give her a new paper as this is going on. The final straw was the third week she came back, and she had not yet asked for care. And so she gave me her permission. I called her grandfather, who was very willing and available to take her into the emergency department, where she received full adequate care, a workup. She indeed had a hemoglobin of 5. It was normally about 13 for a person her age and gender. She received several blood transfusions. Turns out she had very heavy menstrual periods and was losing blood. She couldn't keep up. So she was put on to birth control to regulate and lighten her periods. And she came back to school, a new young woman. It was a real success, but I'd forgotten that this had actually gone on for more than 1 calendar year. So the lesson learned is that HCIS has required preparation to address follow-up and oversight of ACEs patients, including monitoring underlying health conditions. We have access to these students where they maybe don't have access to, or it's been years since they've seen a care provider. Hospital admission, contacting parent or guardian or family member, whoever their adult is, to assist with care plans, and social service advocates for additional resources.
And I would just like to say, Amy had a heroic moment. We had about 30 to 50 athletic students show up to the clinic with this huge thank you card saying, "Thank you, Dr. Amy, for saving our friend's life."
Absolutely great work that we've done. In our previous webinars, we've conducted an activity to show everyone how all this looks in actual practice. This will be the conclusion of our case study that we have presented that demonstrates how healthcare integrated services has detected, addressed, and followed through with cases involving ACEs impacted youth. Additionally, the case study that we are presenting and that was previously presented in our previous webinar series is not based on any one particular patient's experiences. Instead, we've created a synthetic case study informed by our experiences over the past 20 years. However, even though that this is a fictional case study, you should not think of this as an unrealistic scenario.
Sadly, this is not unrealistic at all. A 16-year-old female patient comes in. She came in for a pregnancy test, which is pretty common for our students. They really don't have any idea, other than having had intercourse, how long it takes to show a pregnancy test positive. Could certain sexual activities cause them to become pregnant? They really don't have much of an idea. But this patient came in for a pregnancy test. The patient completes the intake. She consented as a minor because this is related to her sexuality. Routine trauma questionnaire was administered, and she had a self-assessment. She revealed traumas around various forms of violence and reported sexual abuse and assault. She did not feel safe at school. She reported thoughts of suicide, isolation, and sadness in the past 6 months. So this had been going on for half a year for this student. Urinalysis screening was negative for STDs, but she was positive for pregnancy. So what did we do? We asked the patient to consent to the universal screening. Once the patient consented, she was universally screened through the Pearl tool. She screened positive for ACEs. HCIS met with the patient and reminded her of her confidentiality rights and assured her safety. That was part of the rapport relationship that we had built with her. HCIS then reviewed her electronic health records and also contacted the school principal and the campus police. We coordinated with the PET team for a 5585, which for those of you that don't know, that's somebody under 18, a minor. It's a kid version of a 5150 hold to protect the patient due to her suicidal ideation. HCIS also worked with school officials to contact guardians for their involvement.
So at this point in time, we'd like to open up for discussion from the audience with our panel. You will be able to unmute yourselves. There's no need to feel shy. Our panel would love to discuss this case study and any parts of it that was previously established with our audience. If you're unable to unmute yourself, there is a chat feature that you can participate in, and we can relay your thoughts or questions to the panel. And so at this time, we'd like to begin the discussion, and we can open it up to our practitioners.
Well, what we did, the campus police were notified, an incident report was completed, the violent student was removed from campus, there was a crime investigation that was begun, the student victim was moved to a different school district, but coordination of care plans with this network of necessary services, decisions may involve transfer of the student victim to another district, which is what happened, and follow up with a therapist for ongoing counseling and family counseling.
So at this time, feel free to jump in. Other panelists can share in the discussion. We do have prompts on the screen to help guide any discussions. Feel free to share any thoughts on the subject matter on continuity of care.
Well, I'll start out. When students trust and reveal trauma issues and become comfortable with sharing, they seek help and oftentimes spread the word to their friends and siblings. And so I would just like to say it's important that you must stick around and remain consistent with services and be available for the students, because they will refer their siblings and friends to receive help.
distance, optimal position. So he's got the launch monitor there in front of him, but I think back to range. He was over in front of the teaching building here at TPC Sawgrass, and he was using a camera that was overhead going looking down on the golf ball. He referenced it just in his sound.
Are there any additional thoughts to this case study that we presented today?
Yeah, I have one. Can you hear me?
Yes.
It's probably a dumb question, but given the COVID scenario, don't you think, the question to the panelists, don't you think that there's a real serious need to have situations like you speak of, I mean, from an organizational perspective, in place when students return to school, given the fact that they've been off and they have issues of communication and transition and all the things that go along with them having been educated for now a year via computer? Hello?
Yes, we could hear you. Would any of our
Okay.
panelists like to jump on this question?
Yes, on the previous webinars, we discussed how services and trauma and crisis do not stop during holidays or after school or during summer breaks. So we have set up a system where students can call in or access us on the website to receive help. And we're always open to receive students at any time. But you're right, Mr. Swift, it doesn't stop. The doors are always open, and there has been provisions made through Los Angeles County Office of Education to have wellness centers available on all the campuses. So the doors are open at these wellness centers, which is a new service to make available for students experiencing trauma at any time.
Good.
Thank you for your question or your statement.
This is Dr. Hardy. I'd like to respond to it too. The issue though with the wellness centers is there are some schools, and I've actually been medical director of a local school, but depending on whether they are FQHC, which is a federal qualified clinic, in those clinics, they don't just see students. They see people from the community. And in those settings, there's not the time available to allow for the students to deal with more confidential issues like sexuality, pregnancy testing. And if there's not a female provider, or sometimes men want to see a male provider, that's also an issue. So we need to make sure if we do have it in wellness schools, we also have the availability for confidentiality, and the setting needs to be set for students. So sometimes they'll pop in between class, and are they going to have to wait for it? Will someone deal with them immediately? And that's the issue with some of the schools that I work with. But I agree.
We have an excellent question from Bishani. Her question is a student able to deny the 72-hour hold, or does that become a mandatory placement? Her second question is, if it is mandatory, does that create a rift in the trust that you've developed with them? These are both excellent questions. Dr. Amy or Dr. Hardy, would you like to respond?
I would love to respond to that. So just like an adult 5150, that is a legal document that is binding. Even though this is a minor, we make certain that they understand that this is for their safety or the safety of somebody else, or essentially their safety. So basically the criteria is, are they a danger to themselves? Are they a danger to somebody else? Or can they take care of themselves? Do they have a plan on how they will do they have a place to stay? Can they clothe themselves? Can they care for themselves? They cannot, just as an adult, cannot refuse a 5150. It is mandatory. It's a 72-hour hold is absolutely mandatory, but it hasn't caused a rift in the trust with us so far. In fact, it does the opposite. Students, I think by and large, students don't want to cause any ruckus at home or in school or with their friends. They just kind of want to get along to go along. And sometimes they're really suffering. And so it's a sign to them that we take them, that we see them, that we take them very seriously, and that we care, and that we are making sure that limits are set for their safety. So in fact, the opposite is true. They come back to us for continued care. They're grateful that somebody is paying attention and, you know, someone's got them.
I also echo the same thing. Remember also, doctors and providers are mandatory reporters. So if we think someone is suicidal or homicidal and we fail to act, then that responsibility falls on us. So yes, we want to maintain the trust, but if this is an emergency, we're, as mandated reporters, we have to act. And if we decide that the person is suicidal or homicidal, we'll do what's necessary. And then, again, Amy just shared that it doesn't necessarily destroy the trust, but in an emergency situation, that's what the provider is thinking. Let's save their life. If they kill themselves, there's no one to have mistrust with. So, yeah.
Can I say one more thing about that? We had a student one time who came in for the physical exam, and there are screening questions built into every physical exam and interview, such as, you know, safety, have they ever thought about suicide? Are they using drugs? Is anybody forcing them to have sex? Do they have a safe place to stay, et cetera, et cetera. And I had a student who finally revealed that, yes, he actually had an extremely detailed plan about how he would try to kill himself with backup plans. And then he said, you know, I was going to come in here and I wasn't going to say anything, but then I just opened my mouth and it all spilled out. And that is, we see that time and again, maybe not to the extent that that student had, but they're so grateful that somebody is asking the questions.
Additionally, Amy and Dr. Hardy, you do extensive counseling with the patient to let them know that this is something that we can't ignore, and we're going to have to take protocols, steps, and actions, and this is for your safety. So there's an entire dialogue that goes along with it. The person isn't just carted off and put in an ambulance or in a police car. It's usually extensive time that goes into putting them in the hospital. I think one time, Amy, you were at the clinic for like 6-7 hours just to go through this process.
Oh yeah, it was past dinner time. Put her in the ambulance, you know, and the kids come back too and they say, well, you know, things are better, or my family's talking now, or I'm on pills to make me less sad. You know, I'm seeing a counselor twice a week, a therapist. So it really, you know, it can be extremely disruptive to the family system that's allowed this abuse to perpetuate for sometimes years and years and years. It can be extremely disruptive, but it's like ripping off the Band-Aid. You know, you got to see what's festering under there. And in the end, the student benefits, and they know that they do. So I think they're grateful, but it's not comfortable sometimes.
Thank you for the powerful question.
Absolutely. Are there any more thoughts towards this case study discussion? Okay, great. At this point, we'll go ahead and reveal the final case study.
Okay, so follow-up emergency treatment team meeting. Oh, that's not mine. Is it?
Yes.
Okay. Okay. Oh, the slide looks different. Okay. So we meet as a team to discuss the urgent and emergent patients. We created a plan for this particular patient. We continued with her follow-up appointments with the student. We brought her back and back and back, this fictional student, and the family, to ensure that the needs were being addressed. Because, as I said, you know, these dysfunctional systems just simmer, and they work for most of the people in the system, but not everybody. And the students are usually the ones who will volunteer that. When we have suicidal students, we do a no harm contract with the student. There's a therapist involved, and everybody is aware of the Campus Wellness Center and that and the services that they provide. And then we follow up with the outpatient physician to coordinate future service plans, if there is one.
Fantastic. So now in this last segment, we'll just be wrapping up our last webinar for this series.
All right. So again, thank you everybody for making time for this this gathering today, and thank you very much for the great discussion. This was there was some really thought-provoking questions that were asked, so I appreciate the participation this time. So just a quick reminder, as I mentioned at the beginning, we will be sending a webinar evaluation survey to everyone tomorrow. That will be coming into your inboxes, and it is a SurveyMonkey link. So it takes anywhere from 5 to 10 minutes to complete. So if everybody could just set aside a little time to give us feedback on today's session, we would greatly appreciate the feedback. And just as a recap to our webinar series as a whole, we just wanted to revisit this process of becoming ACEs aware, as Dr. Miller talked about earlier. In order to qualify for Medi-Cal reimbursement for ACEs screening, everybody has to take the ACEs Aware training, which is available on the ACEs Aware website at training.acesaware.org. We'll send you this information as well via email, but we just wanted to make sure that we really drive that home, that that training is available for free on the ACEs Aware website. And there is a self-attestation process that follows that. So this is required in order to receive Medi-Cal reimbursement for ACEs screenings. We also wanted to make everyone aware of Healthcare Integrated Services YouTube page. And as we close out our webinar series today, we wanted to let everybody know that these videos will be available on HCIS's YouTube page, along with some other valuable resources and videos. And this is a resource that is continuously updated. So we have put the link in the chat to that YouTube page, and we encourage all of you to subscribe to keep up to date on some of the other activities that we're doing as part of this ACEs Aware initiative. At this point, I want to make sure that we point everybody to some important contacts. Again, information about the ACEs Aware initiative in general can be found at acesaware.org, and questions about healthcare integrated services can be directed to info@healthcareintegratedservices.org. Again, these slides will be posted on the Healthcare Integrated Services website along with the recording of today's webinar. Please feel free to reach out to them at any point if you have any follow-up questions. At this point, I would like to hand it back over to Healthcare Integrated Services just to offer some final remarks on our webinar series.
If you would like to receive more information about healthcare on your school campus or ACEs screening, as Jeremy pointed out, please visit our website to schedule a presentation. Our president, Justin Miller, and the healthcare medical team will be happy to guide you through that process. So again, we would like to thank you for participating. A special thank you to Los Angeles County Office of Education. A special huge thank you to Dr. Victor Thompson. He helped us with the outreach to the county offices and school districts. And we would like to thank Dr. Nadine Burke Harris. It's been a privilege to work with her Special ACEs Aware Initiative, the Surgeon General of California. And thank you to Dr. Hardy, Dr. Amy Dovetail, and a special thank you to Evaluate and our president, Justin Miller.
Right. Thank you so much, everybody. And we hope everybody has a great day and a healthy and resilient 2021.